Yeah. Good morning, everyone. Thanks again for coming to our cardiac sciences grand rounds. And I've heard there's a day of snow coming, so this will be nice and warm before we encounter that. Today we have the opportunity to have Dr. Pranav Bhagirath here. He's a cardiologist and a EP physician at the Amsterdam University Medical Center. His work is very interesting. It sort of brings together clinical electrophysiology, cardiac imaging, and computational modeling. And he really focuses on sort of diagnosis and treatment of ventricular arrhythmias. He's funded from the Ascend VT program from the Dutch Heart Foundation. And it sort of looks at this integrating VT substrate by looking at structural imaging, non-invasive functional mapping, and spectral electrogram analysis in a unified digital twin framework. And he's going to be talking to us about that today. He's trained and collaborated at international centers, including the King's College London, Hospital Clínic Barcelona, and that's where he's currently working on developing and validating non-invasive technologies for creating personalized VT ablation strategies. I guess in his own words, he seeks to move from pixels to patients, transforming complex imaging to computational data in a clinically actionable intelligence. He's also the founder of the Amsterdam Institute of Cardiovascular Imaging, and he serves on several international committees. So welcome, Pranav. I'm looking forward to your talk. Thank you.
Thank you, Vikas, for the kind words. Good morning, everyone. It's a pleasure to be here. Thank you for the invitation. So I've had a bit of a vertical journey, and I would like to share it with you. And it's about going from pixels in an image to patients in the lab. And the main thing I would like to discuss with you is how we can use digital twins as a technology to better understand the mechanisms behind VT and move towards better planning and administration of our VT therapy. So these are my disclosures. As already said, I'm grateful to the Dutch Heart Foundation as well as the European Heart Rhythm Association for funding my research as well as my training work. And equally grateful and thankful to the collaborators who have now turned into mentors. And as you can appreciate from the slide, it's a very wide range of expertise, going from expertise in engineering, imaging, as well as invasive EP. And I think this sketches the last 15 years of my research journey, where I've gone and trained at different institutes, and I've had the privilege of being mentored by leading entities. So moving on, I would like to start off, before diving in deeper about digital twins, I would like to discuss with you the challenge that we face in the VT arena, and particularly about the outcomes that are suboptimal. A couple of slides, just one, and Kaplan-Meier on the MADIT2, where we know that function predicts risk. But thankfully, in the years after, or unfortunately in the years after, we found out, thanks to the Danish as well as the other trials, that it's not for everyone, right? So we have metrics at our disposal that can be used to predict risk for certain patient categories, but not for everyone. Now, when we look at a VT ablation, I think that's even more prominent, because we know from multiple trials, and these are two, I think, prominent ones recently published in JACC and Circulation, where we clearly see the Kaplan-Meiers indicating benefit of ablative therapy, right? So ablation helps. But I think it's equally important to look at the lateral end of the Kaplan-Meiers, where we see that patients that get ablated eventually, in a 2 to 3 year follow-up, have a recurrence rate of about 30 to 50%, which is significant. And we must keep in mind that these are patients being ablated in expert centers by expert operators. So even expert operators doing ablations, still 1 in 3 recurs. And, to me, that brings up the question, what is exactly the thing that we are missing? And I think one of the probable reasons for that is the complexity of the substrate. So this is, I always find, a very illustrative image. This is from work done in Leiden from the group of Professor Zeppenfeld, where they looked at the different types of architecture and the different location of substrate. So when we are, maybe, can you see my mouse? Yeah. So when we look at compact substrate and we have a patient in the lab, we know what to do. But non-ischemic cardiomyopathy, for example, can have different types of architecture and can range all the way from endo to epi as well as intramural substrate. So if I illustrate that using an image, if I were to get a patient with this scan on the table, I know where to map, what to look for. And these are the patients that, when performing ablation, have fairly good outcomes, right? So they have arrhythmia-free rates of 80% up to 2 years. But that changes drastically when one of these patients comes up. And these are cases that I've done in the past months. And for example, this patient, you can see that there is a huge, on the short axis late enhancement image, there is a huge epicardial scar. And this one has a dilated left ventricle with large epicardial as well as tremendous intramural involvement. So I think every patient, and that's particularly goes for non-ischemic cardiomyopathy, is different. Every substrate is different. We need to have patient-specific arrhythmogenicity analysis, because I think it's the gap between what we see versus what really sustains the arrhythmia for that particular patient is where we are lagging behind. So what I would like to discuss with you is the following. I'd like to discuss with you digital twins. And digital twin is a very frequently used term of late. So I would like to distinguish between 3 types of digital twins. One is a structural digital twin that can be derived from anatomical imaging, from CT, MR, PET. That can give you information about patient-specific substrate. We have mechanistic digital twins that we can use as a layer on top of the structural twin to create a functional analysis of the substrate. And then we have a truly functionally equivalent digital twin where we can use high-resolution ECGs to augment the previous 2 twins based on non-invasive, personalized, patient-specific EP metrics. And then finally, I would like to conclude my talk by talking about something that I believe we should be moving towards. And this is still a vision, and I'd like to discuss with you and love to hear your viewpoint on that. So moving on, just a bit about SCAR. This is, can I just get a raise of hands? Who all is an electrophysiologist in the building? Okay, so quite a few. But for the people that are not, this is a histology preparate of an infarct where you have something which we deem as the SCAR core, and there is an entity which we call the border zone, and then there is a preserved sleeve of myocardium, if you will, which we call the conduction corridor. So these are terms to keep in mind, because I'll be reverting during my talk back to these terms. And this is a beautiful histology image that gives us a great understanding about what's needed for substrate-based arrhythmias to occur. But we only get this when the patient encounters the pathologist, and that's not really ideal for procedural planning. So non-invasive substrate assessment, I think, really got a boost when this paper came out. Work done on late gadolinium enhancement imaging. I think you all are familiar with the technique, so I'm not going to dive into it too deep, but very briefly, we administer gadolinium-based contrast agents. We wait typically for a time period between 8 to 15 minutes, and then we acquire images. And essentially what you see is the black areas, the contrast has washed out, so that's a relatively healthy area. And the hyper-enhancing area, or the white areas, are the diseased entities of myocardium. Now, this truly revolutionized the way we perceive substrate. And ever since, we have actually been trying to quantify scar area as mass. We have tried to distinguish and differentiate between core and border zone. And these are just a handful of publications. There are many more that tell us that there is truly a predictive value of these 2 metrics. There is some contradictory evidence or findings in the literature. I'll get to that, the reason behind that, in a bit. Now, of late, we have started using more advanced post-processing tools. So we are now have more sophisticated analysis of that same data set. And what you see in the animation is a left ventricular shell where red is scar core, blue is healthy myocardium, and everything that has a different color, so yellow, orange, is border zone. And this is an animation that goes from the epi to the endo and all the way back. So we now are able to use that image to get a much better understanding of the volumetric nature of that particular substrate. And we can then use these images to derive potential conduction corridors. So these are, let's say, virtual emulation of potential areas of preserved myocardium in that particular scar map. And the great thing is we can then use these maps to integrate them and import them on our electroanatomical mapping systems and really help to guide the procedure of the mapping as well as the ablation. I think one of the metrics that we developed at King's College is called interface, and I think this is a beautiful metric, slightly biased on that, but interface is a very mechanistic approach to understanding substrate. So what we see here is a short axis late enhancement image with the left ventricle and the right ventricle, and you already see that the left ventricle volume has been segmented out. Once again, blue is healthy, red is scar core, and what you see, probably not easily visible for the last row, but there are certain areas of green which are the border zone. And here, what we then subsequently did is we created volumetric meshes of these segmentations, and then we could quantify the interface area. So that's the surface between scar core, border zone, and healthy myocardium, which we found to be an independent predictor of therapy and recurrence. And I think the mechanistic insight that it gave us is that the fact that if you have a large surface area in between your scar core and the other two entities, you have a huge anatomical barrier. So you have your huge circuit which can sustain the arrhythmia. And the same is applicable if you have a large border zone to healthy interface, because that's where the conduction slowing occurs. So that's, you have in this interface metrics at once both of the prerequisites for re-entry to occur. Now, if we look at this slide, we have a huge number of metrics. So ideally, you would say this is good enough, but there are some ifs and buts. And one of those things is the fact that we are doing a post-processing of existing images that have been acquired. And what you see in front of you is an image where we looked at the impact of threshold and the impact of image reconstruction and how that influences the substrate map that we derive. So there are two clinically wide used algorithms, one called full width at half maximum and the other called end standard deviation. They both look at the scar in a different way. So full width at half maximum uses the maximum signal intensity, so looking at the most brightest areas, and the end standard deviation uses your myocardium, your healthy myocardium as a reference, and then uses the standard deviations to distinguish between scar core and border zone. So what you can appreciate is depending upon which post-processing algorithm you use, you already impact the way the substrate maps are visualized. And you can also see that in the quantified numbers where scar core and border zone and the conduction corridors are significantly impacted based upon which post-processing algorithm has been used. And that's even more true when we look at the reconstruction technique. So the magnitude and phase-sensitive imaging for the non-imagers are two images that we acquire during the same late enhancement imaging session. So depending upon what you prefer, phase-sensitive images are less susceptible to let's say, a manual input. So they give brighter images, they give much easier to comprehend images. But as you can appreciate, that also changes the reconstruction drastically. And it is quite powerful as a technique, but it's a bit unsettling that you can really make a patient extremely ill if you go from one reconstruction to the other and make the conduction corridors, the tubes that you can appreciate, either very of low arrhythmogenicity or extremely high protectedness, making it much more likely to be the critical isthmus. So I think it's important to note and keep this in mind when we are doing these analyses and when we are using these images to guide our procedures. What I would like to move on is the in silico modeling. So once you have this digital twin of that patient-specific anatomy, we can then move on and acquire and do computational modeling. So a brief background about computational modeling. It's been around for a very long time. So Hodgkin and Huxley did their first experiments on squid axons, where they looked at action potentials, the registration of the action potential, as well as the visualization. And then they tried to define the differential equations governing this action potential. And that was fairly easy for the squid axon. What we noted is that it's much more complicated when it comes to a cardiomyocyte. But even then, a lot of progress has been made. And these are two prominent groups involved in doing computational modeling. Bordeaux is another one that has recently gained some traction, where we now use patient-specific anatomy and ion kinetics to do patient-specific simulations of activation of VT studies. So how does that work? Creating a digital twin. One of the most important things you need is imaging data, because you need to have the anatomical digital twin. You can incorporate then, after that, the electronic health record data or lab work that you have. But more importantly, you can try to incorporate the ECG to get the functionally equivalent twin. So once you have the anatomy acquired, and once again, that can be using CT, PET, or any other imaging modality, you then create a high-resolution mesh by segmenting out the torso, the thoracic organs, of course, the cardiac compartments, and then you create a high-resolution mesh that will support, that can support algorithms or computations. The next step involves the functional twin. So you use your ECG or your electron-anatomical map as an input and try to calibrate your algorithms to make sure that your prediction closely correlates with what your real or input data, your ground truth data is representing. Now, this is one of these digital twins, and this is actually the first digital twin that I created. And what you see is a non-invasive VT study being performed. What you see is a left ventricle with colors changing. And let me try to see if I can. Yeah. Okay. So what will happen is, if we pause it, so we start pacing. We start doing a non-invasive EP study from any particular area. In this case, between the two areas of infarction. And what you see is that there is a drive time being given. So we are stimulating the ventricle at a cycle length of 600 milliseconds. And then at one point of time, we will now introduce a extra stimulus, so a short coupled extra, which gets blocked in that isthmus region, in that conduction corridor region, and that leads eventually to a figure of 8 reentry. So this is an elegant way, before the patient even lands on the table, to get a good understanding of the EP characteristics. Now, just a quick question to all of you. How long do you think this simulation took to make? And I'm not talking about the video, I'm just talking about the computation required in order to create the simulation. Was it somewhere around a couple of minutes? Just a show of hands, hours, days, weeks? I don't see any hands, so I'll just disclose it to you. It took 70 to 68 hours on a high-performance computing cluster of 256 nodes. So, I set up the simulation, enjoyed the weekend, came back, and then made this movie. And I was hoping that we would see something. But that is the price of precision. That is what we are facing right now. So in order to get these high-resolution simulations, we need reaction diffusion models that really can model the ion kinetics. For that, you need high-resolution models, you need high spatial and temporal resolution, and you need the high-performance computer. And I'm not sure where yours is parked. I'm pretty sure there's one going to be coming here, but there's a lot of high involved. And when we start tweaking the resolution, and there's a reason why that's listed on my slide, because I tried to do that. I did not have the patience to wait for 3 days. I saw that the coarser I made the mesh, the more artifacts I started having. So I had ultra-slow conduction, artificial areas of block and spurious reentry. And, even despite the fact, even if you just increase it from 300 microns to 400 microns, just to try and improve the computational speed, even then it takes almost 1.5 to 2 days. So it's an excellent tool for pre-procedural analysis of the substrate, but real-time use, or let's say peri-procedural use, is not really feasible at this moment of this technology. And that's where VETA comes in. So VETA is a tool. I'm not able to move forward. Okay. VETA is a tool which is not a reaction diffusion, but a reaction iconal computation. So that simplifies the algorithm which we use to compute. We, of course, use an MRI-based model, and we create the geometry. This was the porcine validation study that the colleagues at King's performed. And then we simulate that geometrical model from all different locations. So in this case, for ease of reproduction, the AHA segment, AHA 17 segment model was used. And then we see whether a VT is inducible or not. And of course, if a VT is inducible, we try to identify which ablation targets would help terminate that VT or make it not inducible. And I think one of the most impressive things that's listed in this paper is the computation time, because this takes around 50 minutes. And that's 50 minutes not on a high-performance computer, but that's 50 minutes on my Mac. So that makes it an order of magnitude faster. And if you look at the results, I dare you to guess which is which, because one is the high-performance simulation and the other is VETA. And of course, I know because I made the slide, but otherwise it's fairly impossible, because if you look at the geometrical propagation, it's fairly identical, right? So and this is just the visual analysis. If we look at the numbers of the unique VTs induced, 7 animals were studied. We have comparable numbers. Of course, there are always going to be discrepancies between the high-resolution model, which we called WAP, and the reaction iconal, which is called VETA. There are always going to be discrepancies, but VETA performed at par, at an order of magnitude smaller computational power. So I was fortunate enough to join King's at a moment and do the first in human validation. So I looked at 2 patient cohorts. The first one was a patient cohort of 20 VT ablation patients that we had followed up for almost 5 years. And I looked at whether we could use VETA to understand substrate complexity and try to predict which of these patients was going to recur. So for that purpose, we used the short axis late enhancement images, used ADAS to make a 3D shell, then used a customized Python script pipeline to make the volumetric models, and then performed VETA. So performing VETA in this case meant that we used pace. So in this example, we pace at the LV apex, and then we look at the wavefront and how that propagates throughout the ventricle, and particularly interested in areas that cause splitting of the wavefront. In those areas, we then simulate unidirectional block, and then we try to see if and when VT is induced. And if VT is induced, we look at the round trip time. So how long does it take for the VT circuit to return back to that area of unidirectional block? So we call it the round trip time. It's the in silico equivalent of VT cycle length. Now, when comparing that patient cohort, there were patients that recurred and patients that were arrhythmia-free. What I found was that patients that did not recur had a drastically simplified scar area, as you can see, compared to the patients that did recur, that have much more extensive scar. And what I could also observe when we started to quantify things, is that the number of unique VTs that were inducible was significantly lower, as well as the round trip time. So the length of that circuit was significantly higher in patients that recur. Now, if you think back at what we discussed during the imaging, the anatomical substrate part, the interface area that defines the circuit length essentially comes down to the same thing. So we now have a tool at hand which we can use to get a quick understanding of the functional implications of that particular substrate. So then we did the same exercise for patients that had undergone ICD implants. This was a combined population, eventually ended up increasing the number to 150 patients, ischemic cardiomyopathy patients, pre-implant late enhancement MR, and then followed up for almost 7 to 8 years, looking at therapy, and which was carefully adjudicated in that time period. So we used MR, both the late enhancement reconstructions, both magnitude and phase-sensitive imaging. We created the scar maps, and then we performed modeling on those models. So just disregard these two, because this we have already discussed to some extent. But what you can already appreciate, and the top row shows in this case the patients that had an event during follow-up, which could be ATP or therapy of any form, and patients that did not have an event, they have a drastic difference in the interface area. And if you look at the number of VTs, once again, a higher number of VTs inducible in patients that suffered from an event compared to patients that didn't, and similar results as to the VT cohort regarding the round trip time. So basically, Vita gives us a way to perform, gives us a way to perform patient-specific substrate characterization, looking at inducibility of VTs, looking at how those VTs would react when we give therapy, whether that's device therapy or ablative therapy. There's just one final gap which is remaining, and if we fall back onto the overview, this is not a functionally calibrated digital twin. So these are all estimations that are input in the model that we have, and for that we really need to have add another dimension to it, which we did with ECG imaging, and we tried to incorporate a couple of other EP metrics. So I'm not going to bother you with this. We all know how to read ECGs. We have been drilled and it's been trained. We know how to focus upon where the rhythm is coming from or where the arrhythmia is coming from. Normally, I would ask where it is coming from, but let's skip over. I think so. In order to gain more details, would it be as simple as just increasing the number of leads that we need? And the answer to that, and I'm not sure, there's this unfortunate Zoom bar coming up at the bottom, but so this is a publication. This is work performed in Amsterdam by Professor Dutter, a seminal work where they looked at the total excitation of the human heart, which is also the title of the manuscript. And you can see that there is a biventricular model with extremely detailed isochronal representation of the cardiac activation. Everything I believe that we do ever since is based on this as a foundation. So the study that I would like to discuss with you very briefly was published in Circulation in '97, came from the lab of Professor Yoram Rudy, where what they did was create human-shaped torso tanks filled with saline and that had a canine heart in a Langendorf perfused model suspended in them. And there were epicardial shock electrodes to measure the epicardial potentials, and there were ECG leads, ECG imaging, which was performed on those torsos. And when we look at the reconstruction, so the top row is the measured epicardial potentials, and bottom is the computed or the inverse map. What you can see is that there's a fairly good correlation. And we then started doing this. So this is work that I did during my PhD. We called it non-invasive, but if you look at the patient torso, it probably doesn't entirely look like it. It was. So this is a 64-lead ECG image that was acquired. After the acquisition of the ECG, patients underwent MR imaging, which was then used to segment the torso, the lungs, and the cardiac compartments. These segmentations were then used to create high-resolution finite element meshes, which were then subsequently used for reconstructing cardiac activation. And what you can see here is a rhythm strip where you have sinus beats and rhythm strip where you have the sinus beats and the PVC. And let me go and pause this video. So what you see is that when the PVC is reconstructed, this is the right ventricle with the right ventricular outflow tract, the right atrium, and the left ventricular outflow tract. So we focused on PVCs because they are fairly easy to map as well. And what you can appreciate is that when we start moving, you see that the earliest activation or the site of origin was in this case in the anterior RVOT. So we did a case cohort of that, and we did some RV pacing as well. And what we found is that there was an accuracy of about 6 to 8 millimeters when comparing these models with invasive activation maps. And that's, to me, that's fairly accurate, because if you keep in mind that the ablation catheter that we use to map these normally have a diameter of about 4% or 4 millimeters, that's somewhere in the area in the neighborhood, because these patients are notorious for not having any PVCs when they're in the lab. Despite the accuracy, it was fairly resource intensive. And I say that from personal experience, because it used to take me, and Marco is laughing because he was the co-promoter, but it used to take me about 8 to 10 hours to acquire the ECGI and then get the MR done, post-process, analyze, and then make sure that it's ready for importing into the mapping system. And this has thankfully, grateful to the industry for picking this up, has been resolved. So we have many solutions. The solution that we use in Barcelona is called Acoris, which is from a company, Corify, where there is a disposable sensor vest. It's significantly easier to apply. There's automated 3D body scanning. So we have a digital camera that we use to co-register these electrodes with the cardiac mesh. Acquisition is performed real time, as is the inverse map. Right. So this is something which used to take us a couple of hours on the very least, which is now factually real-time analysis. So this is work which was done on the atria. Let me share with you the validation of this tool, which was just published a couple of months ago in Heart Rhythm, where we have patients with an ischemic cardiomyopathy, once again, a biventricular mesh, the LV, the anterior wall of the LV. I'm sorry, the anterior wall of the LV, the lateral wall, and the inferior. I'm not sure which screen to look at. Sorry, the inferior wall with a lot of areas of scar and border zone. If you look at the electroanatomical map, and for the people who are not used to looking at it, this is the activation time over a surface of area. So depending upon how large a surface is covered by one color, that defines whether there is quick, fast activation, as you can appreciate from here, or whether there is some form of conduction slowing or deceleration. And we call something a deceleration zone when we have 3 or more colors in 1 centimeter area. So what we can appreciate is that the anterior wall has normal activation. There is some conduction slowing in the lateral wall where there was some substrate, and there is a huge area with deceleration zone in the basal inferior wall. Now, when we look at the ECG imaging maps, we can appreciate once again the anterior wall with normal homogeneous activation. There is some conduction slowing in the apical lateral wall, but the most interesting region in this case would be the basal inferior wall. So when we looked at the local signals of that basal inferior wall, what we could appreciate, and this is during sinus rhythm, that there are late potentials. Activation mapping was performed in the patients that tolerated it, and you can see a very nice mid-diastolic potentials, clearly justifying the fact that this is the critical isthmus in this patient. Now, when we bring back the ECG imaging, we can see that during sinus rhythm, as well as during VT, whether we look at the full activation spectrum or whether we distribute it in ILAMs or in 8 isochrones, we get to that same area as the critical isthmus. So using this, we can now reconstruct in a reliable and a quick and a clinically applicable manner ECG images of that particular patient. And that's good for patients that, epicardial solutions are sufficient for. But as we discussed, and that's the reason for getting this image back, we can have different types of substrates ranging from endo to epi, from intramural. So we need to have, to some extent, the 3D element of that data or the volumetric aspect of the data. So that's what's being developed as we speak. And this is a methodological publication, which is close to being accepted, where now we are able to really get into the volume of the myocardium. And I have been tasked with the beautiful job of validating this in the clinical setting. So what I would like to share with you is a case that we did in a patient with an ischemic cardiomyopathy-related VT. So these are, once again, the ADAS maps. We are looking at the septal wall. We are looking at the anterior wall. There's a huge area of scar, of dense scar, as well as border zone. More interesting are these green tubes that you can appreciate, which are the conduction corridors. When we did the ECG image, we did that during pacing as well as during VT. And both of these times, that same septal region came out. So this is a 2-chamber view, where here somewhere the atria would be. This is the anterior wall, the inferior wall, and then we have the septum over here. So you see a nice area of deceleration zone in the septal wall. And when we look at the VT, right ventricle, left ventricle, and the septal wall, you once again see that these are the regions that need to be targeted for ablation or at least would be of interest to be mapped during ablation. So these are the invasive results, where we have a huge area of scar when we look at voltage, and Eva would not be happy for me to show you these voltage maps, but I still think they provide us with some interesting information. We did invasive maps of when we see a lot of areas with deceleration zone, and we did a very brief VT activation map because all things in this case pointed to this septal region, which was then swiftly exchanged for the ablation catheter. We did some ablation to terminate the VT. We had a clear termination. But eventually, because of the extensive nature of the substrate, we decided to homogenize the substrate in a bit more extensive manner, as you can appreciate from the ablation lesions. We then did a remap, and that remap was performed invasively, which took around 10 minutes. But that same remap was performed using ECGI, which just took 1 beat. So that's the difference in the speed and efficiency that we can have with our procedure when we use non-invasive mapping techniques. And we see essentially that the remap shows that area where there was deceleration, that has cleared up, and that's confirmed with the high-resolution endocardial map as well. So basically, this is the point where all these things come together. We have the anatomical twin, we have the simulations, we have the functionally equivalent twins. So essentially, we can perform a pre-procedural planning just based on all this non-invasive diagnostic without ever having to insert a catheter in the patient, and use them to guide our therapy, but also to look at the efficacy of the ablation performed. So more on this, by the way, tomorrow during the EPAM round for the people that are going to be there. But what we now notice is that this precision is meeting some resistance. And of course, we know that certain types of substrate can be very hard to target. Then we are talking about epicardial substrate, intramural substrate. There are certain strategies for it. We can easily go into the epicardial compartment. There are certain catheters that have needles come out of it, which to me is still a very surprising thing that we are really perforating the myocardium. But we also have certain other elegant techniques which being utilized using ethanol in the coronary arteries or in the venous branches. So we have a lot of creativity within our field, within the field of EP. But I think it's also one of the few fields where the solution to scar is more scar. And I think that's some place where we can do better. And we don't necessarily need to harm in order to heal. And that's where I would like to take a minute and discuss with you what I believe should be the way forward. It's out of the box, but I do think it's feasible to a large extent, where I think we need to move from destruction to modulation. And once again, getting back to this is our real target: conduction slowing. And we are very good at ablation. There's a certain periodic substrate, we ablated and the map was cleaned. But how about if we can modulate that activation, not by ablation, but by let's say injecting or applying compounds that affect the conduction velocity? How about if we have a corridor, we can just increase the conduction velocity at that bottleneck? If we have patients with a non-ischemic substrate that have multiple areas of heterogeneity, how about if we just reduce the dispersion across that border zone? And there are compounds being tested for this in majority of the studies in bench, but there are some preclinical work being done in porcine studies as well. And even if it doesn't work, if the isthmus still persists despite the first 2 steps, we can always go and target that intramural substrate by creating a focal block. But so this I think is a framework, is what I think should be our therapeutic strategy for patients with VT. There are certain limitations to it, and I'll be very open about it, because I think those are the same limitations which apply to patients for all the stem cell therapy work that has been done. And I think the 2 major limitations are uptake and delivery. But I think I see them as challenges, and I believe we might already have solved these challenges, but are not completely aware of it. And I think with regard to the uptake issue, there's a role for PFA. So for the people who don't know PFA is irreversible electroporesis. which uses high voltage for a very short time in order to create irreversible damage. But a lot of people might not know that it was designed to be reversible, hence the term irreversible electrophoresis. So this is a mouse study that I found done in 1982 that was where electroporation was used to create, let's say, create pores. This is a cellular membrane depicted at 60,000 magnification. And you can see once you start giving electroporesis, the membrane starts to form pores, hence the term electroporesis. And that goes on and on and on and on until the point of no return when the cell is damaged. But if you stop way before, you can have reversal, complete reversal of that damage. And you can imagine if at this time point you inject something in the vicinity of that myocyte, it will get absorbed fairly quick. So I think PFA, let's still call it PF or PFA, can be used to improve the uptake significantly. And when we look at precise guidance, I think that's where there's a role for interventional MR or MRI-based guidance. I have been involved in the Amsterdam UMC program for interventional MRI when it was conceptualized in 2018. We did the first right heart CATs, so we were amazed at the amount of detail we can see while navigating the cath. We did some animal experiments before really moving on to performing our first typical flutter ablations in the MRI scanner, which was the first one was, I believe, done in 2021. And more of late, I think a couple of weeks ago, the first ischemic VT has been treated in that MRI scanner. There's just one limitation actually of this program, and I think that has to do with the fact that it's a 1.5 Tesla scanner, which does not really have enough tools that we can use. So we now have slowly and steadily started experimenting with the transeptal punctures. We're doing left ventricular ablations, but ideally you would like it to be safe. So you would like to have a defibrillator, which is extensively tested, although we have a workaround solution for it, which can be used in research. But at some point of time, you would like for it to reach clinical application. So I think that's where the lower field, and this is, let's say, low to midfield for the purist, 0.55T scanners come in, where we can probably use, since the fact that there is much less lower magnetic field strength, we can probably use conventional tools that we have lying around, and we can start to at least experiment with them in animal models and see how that results and what that works out to. And there are, of course, a lot of challenges. There's a much lower signal to noise ratio. There is the biggest limitation is probably the fact that you need to have a new scanner, which is not there for the 1.5T because that's the workhorse of cardiology. And in order to set up this program, you need a completely new setup. But I do think that this will tremendously accelerate the adoption of interventional MR, especially for EP purposes. So having said that, let me end it with the direction that I think we can genuinely move towards if we bring the right disciplines together. I've tried to take you from pixels to patients. I think there are three main elements when we are talking about VT work. One is the detection of arrhythmogenic substrate. I think there's a role for the imaging cardiologists and the radiologist, the thoracic radiologist, to make sure that we have the ideal techniques, we have optimized sequences, we have the perfect contrast agents in order to make sure that we have the most accurate detection of the arrhythmogenic substrate. I think the next step is targeting, making sure we are able to target it. And, as EPs, we can do a lot. As imagers, we can do a lot. But there are certain things where we need expertise from our colleagues from the engineering and the medical physics department. And I think involving them in developing novel tools, in developing new ways to look at algorithms is definitely going to enhance the capabilities that we have at this moment. And then finally, of course, the electrophysiologist comes into play when we talk about treating. But I think we need to look at collaborating with other colleagues as well on that front, speaking with molecular biologists to see whether there are novel compounds, whether we can really move towards aligning these pieces and not simply just trying to control an arrhythmia, but to truly cure a patient. And I think using novel therapies that don't just burn tissue, but actually modulate conduction in a very controlled manner, I think we'll end up by doing biomodulation instead of RF ablation. So with that, I'd like to conclude and happy to take any questions.
That was a great talk, and maybe we'll start with questions on any online. I can't. No, not yet. Okay, maybe in the room then we'll start. Yeah, we'll go with Rob first and then Carlos.
Yeah, relation. So you talked about the role of sort of our complexity, simple versus. Another thing that I'm curious about, and whether you have any insight on, is fibrosis can be a very progressive condition. So what about changes in the scar and pathways? How much of it is due to initial complexity versus changes in the pattern of fibrosis over time?
Yeah, completely justified question. That was one of the reasons why I opted to go for an ischemic cardiomyopathy cohort, and why you see a lot of the trials being performed in ischemic patients, because if there is no interim events, you just have that limited area of scar. I think it's to a large extent applicable to certain non-ischemic cardiomyopathies, the progression of substrate, definitely not all. Those are things we are only going to find out once we start doing serial imaging, once we start doing serial electroanatomical maps or ECGI maps. So definitely all the more reason, I would say, to go for biomodulation instead of burning. Because, if you're burning an ischemic scar, that that's really dead tissue with probably just a couple of sleeves, and you can ablate them and be done with it. But when we are talking about non-ischemics, and we have all seen the cases in our labs, you end up probably burning more and probably having a couple of points of the EF go away, or the ventricle to dilate slightly more. So yeah, I think there is an important role for sequential imaging, but an equally important thing that we need to keep in mind on how we treat these patients. And that goes for any technology, right? So that's not just RF, but that definitely is applicable for cryo, and I think to a large extent PF as well.
Yeah, great talk. Also on the same line as Rob's question, I think one of the factors is that the disease progresses, and that's why sometimes we're not very successful. Now, the other question is that you did show that those that had more VTs were the ones that predicted that had a worse successful ablation. And do you think this is, how do you tackle that? Do you have to actually ablate all of these VTs? Because that's creating even more scar, and then maybe be counterproductive. And the other thing is that, some of the work that I'm doing with my colleagues in Spain is trying to create some tenolosome rescuing proteins and delivering them to these sites instead of burning stuff.
So let me start with the second thing and start to congratulate you on that work, because I think that's indeed the way we need to move forward. Instead of ablating, we need to look at other ways of treating these patients. As far as the first question goes, of course, progression is always going to be an issue. And once again, I fall back to that same answer, because if you ablate more in ischemic patients, you're probably not going to damage more. It's more than likely it's dead tissue, and that cannot get any more dead. If you're looking at non-ischemics, particularly in the younger patient categories with a lot of VTs, I think the goal would be, if we persist on going towards the ablative therapy, then it would be to target the conduction velocity issues, right? So if we can target ablation based on areas that are really in need in order to restore conduction, then that makes much more sense. And that's what the studies by, I think, Marta Riva da Silva and also by Ivo Rocaluque have shown that if you target, and also by Tav D'Angelo, by the way, in the UK, is that if you target these areas of conduction slowing, you don't need to perform substrate homogenization. You can just make sure that the conduction bottlenecks are targeted.
Yeah, but the problem there, because the images you showed, there's still a lot of red balls there. So you're still
Ischemic patient.
spreading a lot of stuff, man. So you're not, yeah, I'm not buying that. The question is, how do you determine what is your threshold when you've already changed that conduction velocity? How do you measure that?
Yeah, I think it's very that work is actually being performed as we speak, right? So all the people studying the functional elements of substrate mapping are doing that, are trying to make sure that there are cutoff values for peak frequency, that we know how deceleration zones work, that we know what the decrement evoked potentials represent, right? What is the cutoff value for a deep? Is it 20 milliseconds? Is it 50 milliseconds? Which is more relevant? This patient was an exception. I can show you 5 cases, and I already prepared that talk for tomorrow, and I hope you join in the EP round. Even if you don't, we might end up catching up, because I think we have now started targeting substrate. We actually did an epicardial Brugada patient last week, where essentially we just targeted the two regions in the RVOT and 1 region in the tricuspid annulus, and the complete conduction velocity was restored.
Yeah, but the Brugada is a very different substrate. You know, there's not a lot of doses, and you know, I accept that that's very interesting, but it's a very different substrate from ischemic, non-ischemic cardiomyopathy.
Right. I mean, I once again, you're right to a large extent, but I think even if you have extensive non-ischemic substrates, essentially you need to make sure that the predisposing factors for reentry are gone, right? That's the goal. So then it doesn't make sense to completely ablate all the substrate, right? If you could just target that conduction corridor, and that's where the first step comes in, the detection of that substrate. If you have accurate detection, if you have accurate targeting, you can easily treat it.
Nothing on the chat. Okay. Maybe I'll ask one other question too. And sort of relates to the conduction velocity idea. So, for people, that are not familiar with this concept, so we have something called stereotactic radioablation, where we actually use, these are end-stage patients where we've done VT ablation, traditional catheter ablation, antiarrhythmic still not working. We actually take them to the cancer center, and our radiation oncology colleagues, we work with them to target areas where we think it could be coming. I think it's still, big controversial, does it work? So we're doing it as a local study. We've done a few patients, also don't know the long-term implications. And one of the postulated mechanism is that it changes the conduction velocity, and that's why, you don't get the VT. Let's assume it works, and maybe in 10 years we've perfected the technique. To me, this seems to pair exactly with that, where you don't need to do anything invasive. You can actually just take the patient to the, your radiation oncology suite, where to target, and it's, right? Yeah.
I think that's definitely a good way to move forward. We now have a cohort of about 10 patients in Barcelona that I've just analyzed. Aside from the fact that we are still not clear about the mechanism, whether that's upregulation, downregulation. There are a lot of animal studies on that. We have serial MRs in this patient category. So we have baseline 3 months and 12 months, and we see increase of fibrosis in all these patients. Interesting. Increase of enhancement. Let me be very careful with the images here. So there is an increase of enhancement, which then I consider as a surrogate of fibrosis. So there is, and then you see dilatation of the left ventricle. You see some reduction in EF. Absolutely, if at some point of time we are just able to pinpoint the specific corridor, it would be an ideal technique, as would be any form of regenerative medicine, right? So I think the more we can stay in a non-invasive manner, the better it would be, but probably not everybody. Some people will end up requiring invasive TARO treatment anyhow. Yeah.
When mentioned the needle catheters, they actually came from the original stem cell delivery catheters, and they've been playing with delivery. Sorry, go ahead, Catherine.
I want to take you to 2025, 2026 versus 2020. Okay.
Okay.
to what with your algorithms that you've used and the pictures that you can come up with targeting right now, are you suggesting that may be a first line treatment for VT? Is it good enough for that? And also, can that result in not putting in an ICD?
That's, I think, a very interesting question because the ICD debate has been going on for a long time, especially for the non-ischemic patients, the ones that we are really getting interested in now. And I think if you have, and this needs to be investigated, of course, in a randomized trial. Unfortunately, I'm not sure how the ethics is going to buy it. So we need some pilot data, or a lot of extensive pilot data in multiple centers. But I do think that if you are sure about your efficacy of your therapy, which I think we have now reliable non-invasive markers, right? With late enhancement, we can evaluate it. We have functional markers. We can simulate. So if you give any sort of compound locally and you see that the conduction velocity changes drastically and there is no more reentry to be found, then I do believe that you don't need to give a patient an ICD because it's not, once again, it's not the function that defines.
Stop giving ICDs?
Sorry?
Have you stopped putting in ICDs?
It's 2050 you were speaking about.
The rest of your talk was 2050. What can we do today? Are you secure enough with the algorithms you're doing and the ablation you're doing that you would not put in an ICD in some of those patients?
In some of those patients, absolutely. Yes, we have those examples in Barcelona, absolutely.
Yeah. I guess the other unknown that happened is if we get rid of the VT, are you going to get rid of the VF? That could still happen.
Yes, well, this is what I'm getting at. How convinced are you that you will not put in an ICD?
It depends on the mechanism. Depends on if it's a monomorphic VT, I'm fairly convinced. If it's idiopathic VF, I mean, nobody knows. If it's periaortic substrate. So once again, it depends on the mechanism, depends on the etiology of the cardiomyopathy. But I think in a large patient group with preserved, or let's say mid-range preserved ejection fraction, I think that would be a fair enough way to move forward. Yeah.
No medication, no beta blockers, no amiodarone, no ICD.
Ideal scenario, yes.
But no, that's misinterpreting the Danish study. Because the Danish study, the secondary outcome was actually prevention of VTVF, and there was a 50% relative risk reduction in that outcome. So the ICD does what it has to do, which is prevent VTVF.
Yeah.
It was never meant to prevent all-cause mortality. So you got to be careful when you interpret that and what you wish in the future. Sorry.
No, that's okay. I mean, there's only a minute left, and so we won't belabor this question. I can talk afterwards. But how generalizable do you think the current definitions for bortezone, dense scar, and how we define channels using existing commercial products? How generalizable is that from ischemic over to the different non-ischemic states?
It's not.
And do we need to pursue definitive definitions?
Absolutely. Preferably for each and every non-ischemic etiology, yes. And we are right now using it because we have no other tools or no other definitions. And, we rather have some kind of an input instead of having, just an estimation, right? So I think that's, ideally speaking, you'd like to have a large cohort of patients, well genotyped, well phenotyped with MR, and perform the substrate characterization on that group.